Welcome to Pediatric Case Review. Today we are covering phenylketonuria, a comprehensive case-based review designed for general pediatricians. Phenylketonuria is one of the most important treatable inborn errors of metabolism. Early detection through newborn screening and lifelong dietary management can completely prevent the devastating neurological consequences of this condition. We will walk through 14 clinical cases covering newborn screening interpretation, clinical presentation, physical examination findings, pathophysiology, the essential cofactor, diagnostic workup, phenotype classification, dietary management, pharmacotherapy, maternal phenylketonuria syndrome, and adolescent adherence challenges. Let us begin. Case 1. A 3-day-old infant is referred after a routine newborn screen, returned normal results. However, repeat blood phenylalanine is now 1,420 micromoles per liter. The infant had early hospital discharge at 18 hours of age. What most likely explains the false negative newborn screen? Option A. Premature discharge before adequate protein intake. Option B. Laboratory technical error in the screening assay. Option C. Maternal low phenylalanine diet during pregnancy. Option D. Concomitant neonatal jaundice interfering with assay. The correct answer is Option A. Premature discharge before adequate protein intake. Newborn screening for phenylketonuria requires sufficient dietary phenylalanine to be detectable in the blood. At birth, phenylalanine levels are normal. After 24 to 48 hours of protein intake through feeding, phenylalanine begins to rise. The optimal screening window is after 48 hours. When infants are discharged early, before 24 hours, the screen is taken before phenylalanine has risen sufficiently, resulting in a false negative result. Other risk factors for false negatives include low protein intake, prematurity with delayed metabolic response, and rarely laboratory technical error. Normal phenylalanine is below 120 micromoles per liter. Levels above 120 trigger confirmatory testing. Case 2. A 4-month-old infant is referred for evaluation. The chief complaint is developmental delay. On examination, there is hypotonia and an eczematous rash. A musty or mousy smell is noted. Laboratory testing shows plasma phenylalanine of 1,380 micromoles per liter. The newborn screen was reported normal at birth. What is the most likely diagnosis? Option A. Maple syrup urine disease. Option B. Hypothyroidism. Option C. Classic phenylketonuria. Option D. Biotinidase deficiency. The correct answer is Option C. Classic phenylketonuria. This case illustrates the classic delayed presentation. Symptoms appear 3 to 6 months after birth, not at birth. Plasma phenylalanine above 1,200 micromoles per liter confirms classical phenylketonuria. The combination of neurotoxicity and skin findings represents the delayed but classic presentation. A normal newborn screen may indicate a late or missed diagnosis, possibly due to early discharge. Neurological findings include developmental delay, hypotonia, irritability, and tremors. Dermatological findings include eczema-like rash, fair skin and light hair compared to family members, and a musty body odor. Remember, newborns with phenylketonuria look completely normal at birth. Symptoms emerge only after protein feeding begins. Case 3. A 6-month-old infant is brought for routine follow-up. Parents note progressively pale skin and unusually light blonde hair since birth, despite both parents having dark complexions. Plasma phenylalanine is 1,450 micromoles per liter. What is the most likely pathophysiological mechanism responsible for this infant's hypopigmentation? Option A. Elevated phenylalanine directly destroys melanocytes. Option B. A separate genetic mutation affects pigmentation genes. Option C. Tyrosine deficiency impairs melanin production. Option D. Autoimmune destruction of pigment-producing cells. The correct answer is Option C. Tyrosine deficiency impairs melanin production. In phenylketonuria, phenylalanine hydroxylase is deficient, so phenylalanine accumulates, and its conversion to tyrosine is blocked. Since tyrosine is the direct precursor for melanin synthesis via the tyrosinase enzyme pathway, low tyrosine means melanocytes lack their substrate. The result is reduced melanin production leading to fair skin, blonde or light hair, and blue eyes. which is the classic hypopigmentation pattern in phenylketonuria. This occurs even in families with dark complexions. Melanin synthesis requires tyrosine as its direct precursor. Elevated phenylalanine does not directly destroy melanocytes, and this is not an autoimmune process or a separate genetic mutation. Case 4. An 8-month-old infant is brought for evaluation of increasing tremors and hyperactivity since 5 months of age. Newborn screening was reportedly normal. No family history of neurological disease. On examination, there is fair skin, blonde hair, hypotonia, fine upper limb tremors, and excessive irritability. Plasma phenylalanine is 1,480 micromoles per liter. Which neurotransmitter imbalance best explains the tremors and hyperactivity in this infant? Option A. Excess serotonin causes neuronal overstimulation. Option B. Gamma-aminobutyric acid deficiency leads to motor instability. Option C. Glutamate excitotoxicity triggers cortical seizures. Option D. Reduced dopamine due to impaired tyrosine availability. The correct answer is option D. Reduced dopamine due to impaired tyrosine availability. In phenylketonuria, phenylalanine hydroxylase deficiency means phenylalanine cannot convert to tyrosine. Low tyrosine leads to low catecholamines, meaning dopamine, norepinephrine, and epinephrine are all depleted. Dopamine deficiency specifically causes tremors, hyperactivity, and attention deficits. The primary pathway affected is catecholamine synthesis, not serotonin, gamma-aminobutyric acid, or glutamate. This is an important clinical pearl. Behavioral symptoms in phenylketonuria reflect dopamine depletion, not serotonin depletion. The clinical consequences of dopamine depletion include tremors from motor instability, hyperactivity with attention deficits, and mood disorders with behavioral changes. Case 5. A 5-month-old infant is referred after a positive newborn screen. Plasma phenylalanine is 1,480 micromoles per liter. His diet has included standard infant formula since birth. He has no dysmorphic features. Which enzyme deficiency is directly responsible for the toxic accumulation of phenylalanine in classic phenylketonuria? Option A. Phenylalanine hydroxylase. Option B. Tyrosine aminotransferase. Option C. Dihydropteridine reductase. Option D. Guanosine triphosphate cyclohydrolase 1. The correct answer is option A. Phenylalanine hydroxylase deficiency. This enzyme converts phenylalanine to tyrosine in the liver. When phenylalanine hydroxylase is deficient, phenylalanine accumulates to levels above 1,200 micromoles per liter. Tyrosine becomes conditionally essential because the body can no longer produce it from phenylalanine. Neurotoxic metabolites also form, including phenylpyruvate, phenylactate, and phenylacetate, which produce the characteristic musty odor. Brain damage results from both phenylalanine toxicity and tyrosine deficiency. Without phenylalanine hydroxylase, the brain is starved of tyrosine, which is the precursor to dopamine and norepinephrine. Case 6. A 5-month-old infant is found to have elevated plasma phenylalanine of 980 micromoles per liter on confirmatory testing. Newborn screening was initially positive. Phenylalanine hydroxylase gene sequencing reveals only one heterozygous variant, which is insufficient to explain the degree of hyperphenylaninemia. A Terran profile analysis is ordered. Which molecule is the critical cofactor required for phenylalanine hydroxylase to convert phenylalanine to tyrosine? Option A. Pyridoxal phosphate, also known as vitamin B6. Option B. Flavin adenine dinucleotide. Option C. Tetrahydrobiopterin. Option D. Nicotinamide adenine dinucleotide. The correct answer is option C. Tetrahydrobiopterin. Tetrahydrobiopterin binds the catalytic domain of phenylalanine hydroxylase and enables the conversion of phenylalanine to tyrosine. When tetrahydrobiopterin is deficient, phenylalanine accumulates even if the phenylalanine hydroxylase gene is normal. Tetrahydrobiopterin is also required by tyrosine hydroxylase and tryptophan hydroxylase, so its deficiency affects dopamine and serotonin synthesis as well. This causes neurological damage beyond what is seen in classic phenylketonuria. Tetrahydrobiopterin deficiency mimics phenylketonuria, so always check the Terran profile and perform a tetrahydrobiopterin loading test in any infant with elevated phenylalanine. Tetrahydrobiopterin is regenerated through the dihydropteridine reductase cycle. Case 7. A 5-day-old newborn's dried blood spot screen returns with phenylalanine of 125 micromoles per liter, which is a positive result. The infant is feeding well and appears clinically normal. What is the immediate next step? Option A. Immediately start a low phenylalanine diet. Option B. Repeat newborn screen at 1 week. Option C. Confirmatory plasma phenylalanine and tyrosine levels. Option D. Initiate sapropterin therapy. The correct answer is option C. Confirmatory plasma phenylalanine and tyrosine levels. A single elevated screen does not equal a diagnosis. Repeat confirmatory testing is required. Plasma phenylalanine and tyrosine should be measured within 72 hours per the 2023 guidelines. A phenylalanine to tyrosine ratio above 2.0 suggests phenylketonuria. Starting a diet before confirmation risks unnecessary restriction. The diagnostic pathway proceeds from newborn heel prick with tandem mass spectrometry, to elevated phenylalanine on screen, to confirmatory plasma testing, then phenylalanine hydroxylase gene sequencing, and finally a tetrahydrobiopterin loading test, if indicated. Remember, a positive screen is an alert, not a diagnosis. Always confirm. Case 8. A 3-year-old boy is referred for evaluation of persistently elevated plasma phenylalanine levels detected on repeat testing. Plasma phenylalanine is 1,480 micromoles per liter. Genetic analysis reveals 2 pathogenic variants in the phenylalanine hydroxylase gene in a compound heterozygous pattern. He has no dysmorphic features and is developing normally on a low phenylalanine diet. What do these genetic findings confirm? Option A. Tetrahydrobiopterin deficiency requiring cofactor replacement. Option B. The need for enzyme replacement therapy. Option C. Definitive diagnosis of phenylketonuria. Option D. Classical phenylketonuria phenotype based on phenylalanine level alone. The correct answer is option C. Definitive diagnosis of phenylketonuria. Biallelic phenylalanine hydroxylase variants, meaning 2 pathogenic mutations with 1 from each parent, confirm the diagnosis. This confirms the autosomal recessive inheritance pattern. Genetic testing is recommended at birth alongside confirmatory plasma phenylalanine. It guides prognosis and sapropterin responsiveness. Some mutations, such as the arginine 408 to tryptophan variant, predict tetrahydrobiopterin response. The phenylalanine hydroxylase gene is located on chromosome 12 at position Q22 to Q24.1 and contains 13 exons. 2 null variants predict classical phenylketonuria that is unlikely to respond to tetrahydrobiopterin. 1 null plus 1 mild variant suggests possible response. 2 mild variants suggest likely response. Case 9. A 7-month-old infant is found to have persistent hyperphenylaninemia on follow-up testing. Plasma phenylalanine is 680 micromoles per liter. Phenylalanine hydroxylase gene sequencing reveals a mild heterozygous variant. The metabolic team decides to perform a sapropterin, also known as tetrahydrobiopterin, loading trial. What result defines a positive response to the tetrahydrobiopterin loading test? Option A. Phenylalanine reduction of 30% or more after 3 days. Option B. Phenylalanine reduction of 10% or more after 1 day. Option C. Phenylalanine increase by 50% after 24 hours. Option D. No change in phenylalanine after 7 days. The correct answer is option A. Phenylalanine reduction of 30% or more after 3 days of sapropterin. Sapropterin, marketed as Covan, is a synthetic form of tetrahydrobiopterin that enhances residual phenylalanine hydroxylase activity. The loading test protocol involves measuring baseline fasting plasma phenylalanine on day 0, administering sapropterin at 20 mg per kilogram per day orally while continuing the normal diet, then repeating plasma phenylalanine on day 3. If there is a 30% or greater reduction, the patient is tetrahydrobiopterin responsive. Approximately 49% of phenylketonuria patients respond. The best responders have mild mutations with some residual enzyme function. Non-responders still benefit from dietary therapy. The tetrahydrobiopterin test guides, but does not replace management. Case 10. A A 6-week-old male infant is referred after newborn screening. Plasma phenylalanine on confirmatory testing is 1,480 micromoles per liter. Tyrosine level is low. He is currently asymptomatic with no dietary treatment yet initiated. Which phenotype classification best describes this infant's condition? Option A, mild hyperphenylanemia. Option B, mild phenylketonuria. Option C, tetrahydrobiopterin deficiency. Option D, classical phenylketonuria. The correct answer is option D, classical phenylketonuria. Plasma phenylalanine above 1,200 micromoles per liter defines the classical phenotype, which is the most severe form. It reflects the highest phenylalanine level and the lowest residual phenylalanine hydroxylase activity. Classical phenylketonuria requires lifelong mandatory dietary restriction. If untreated, there is risk of irreversible intellectual disability. The phenotype spectrum ranges from benign hyperphenylanemia below 360 micromoles per liter requiring no treatment to mild hyperphenylanemia between 360 and 600 often requiring treatment to mild phenylketonuria between 600 and 1,200 requiring treatment to classical phenylketonuria above 1,200 requiring lifelong treatment. Higher phenylalanine equals lower residual enzyme activity equals more severe disease. Case 11. A 7-month-old infant with classic phenylketonuria is on a phenylalanine-restricted diet and amino acid formula. Her latest metabolic panel is being reviewed at her follow-up visit. What is the recommended target blood phenylalanine level for this infant? Option A, 120 to 360 micromoles per liter. Option B, 400 to 600 micromoles per liter. Option C, 600 to 900 micromoles per liter. Option D, below 120 micromoles per liter. The correct answer is option A, 120 to 360 micromoles per liter. This is the target range recommended by the 2023 guidelines for all life stages. Levels below 120 risk intrauterine growth restriction, particularly important during pregnancy. Levels above 360 cause neurotoxicity and cognitive harm. The target is the same for infants 0 to 12 months, children 1 to 12 years, adolescents 13 to 18 years, and during pregnancy. For adults over 18, the target is at or below 360. Twice-weekly monitoring is required during pregnancy. Early dietary control equals normal neurodevelopmental outcomes. Case 12. A 7-year-old boy with confirmed phenylalanine hydroxylase deficient phenylketonuria has been on a strict low phenylalanine diet since birth. His current plasma phenylalanine is 680 micromoles per liter despite good dietary adherence. His metabolic team performs a tetrahydrobiopterin loading test, and his plasma phenylalanine drops by 42% after 3 days. The team decides to add sapropterin to his management plan. What is the primary mechanism by which sapropterin reduces plasma phenylalanine levels in phenylketonuria? Option A, directly blocks phenylalanine absorption from the gut. Option B, replaces the deficient phenylalanine hydroxylase enzyme entirely. Option C, enhances residual phenylalanine hydroxylase enzyme activity by stabilizing the enzyme. Option D, increases urinary excretion of excess phenylalanine. The correct answer is option C, enhances residual phenylalanine hydroxylase enzyme activity by stabilizing the enzyme. Sapropterin is a synthetic form of tetrahydrobiopterin, the natural cofactor of phenylalanine hydroxylase. It acts as a molecular chaperone, stabilizing misfolded mutant phenylalanine hydroxylase protein. This restores partial enzyme activity, so more phenylalanine is converted to tyrosine. It is effective only in patients with residual enzyme function, typically those with mild to moderate mutations. The response rate is approximately 49% of phenylketonuria patients showing 30% or greater phenylalanine reduction. The best responders have mild phenylalanine hydroxylase mutations with some residual activity. Classical phenylketonuria with zero enzyme activity is unlikely to respond. Case 13. A 26-year-old woman with known phenylketonuria presents at 6 weeks gestation. Her plasma phenylalanine is 890 micromoles per liter. She stopped dietary management at age 18. What is the most critical intervention to prevent fetal malformations? Option A, Start folic acid supplementation immediately. Option B. Initiate cypropirin therapy at full dose. Option C. Restore strict low phenylalanine diet to achieve phenylalanine of 120 to 360 micromoles per liter. Option D. Refer to maternal fetal medicine and delay intervention until the second trimester. The correct answer is option C. Restore strict low phenylalanine diet to maintain maternal phenylalanine between 120 and 360 micromoles per liter before and throughout pregnancy. This is maternal phenylketonuria syndrome, which is completely preventable with strict metabolic control. Phenylalanine monitoring must be done twice weekly during pregnancy. Uncontrolled maternal phenylalanine causes devastating fetal effects. Phenylalanine above 360 micromoles per liter causes microcephaly with head circumference below the third percentile. Above 600 micromoles per liter, congenital heart defects develop, including ventricular septal defects and conotruncal anomalies. Uncontrolled phenylalanine at any elevated level causes irreversible cognitive impairment in the fetus. Ideally, phenylalanine should be controlled before conception. Case 14. A 16-year-old girl with known phenylketonuria is seen at her metabolic clinic. Her plasma phenylalanine has risen to 820 micromoles per liter over the past 6 months. She admits to frequently skipping her medical formula and eating regular food at school and social events. What is the primary driver of poor dietary compliance in this age group? Option A. Unpleasant taste of medical formula. Option B. Lack of parental supervision at home. Option C. Insufficient understanding of phenylketonuria risks. Option D. Social pressure and desire for normal eating patterns. The correct answer is option D. Social pressure, peer influence, and desire for normal eating patterns. Adolescence is a time of identity formation and independence, and the restrictive phenylketonuria diet conflicts with social norms. Food is inherently social, and parties, school lunches, and peer meals create daily challenges. Poor adherence raises the risk of cognitive decline and mood disorders. Psychosocial support and structured education significantly improve outcomes. Key challenges include peer pressure, food restriction fatigue, social events, and mood and anxiety related to diet burden. Support strategies include psychologist referral for early mental health support, peer support groups to connect with other phenylketonuria adolescents, structured education to teach self-management skills, and family involvement for caregiver coaching. Involve a psychologist early because dietary adherence is as much emotional as medical. Before we wrap up, I want to tell you about our community called Pediatric Case Review. In this community, you will find a full case library with all pediatric case reviews organized by body system for rapid, easy access. All presentations are available as high-resolution downloadable images for offline study and teaching. We also offer direct support. For details on how to subscribe, comment below in this post, and we will message you directly with full access details. Let us now review the 6 key clinical takeaways from today's lecture. First, screen early. All newborns must be screened within 24 to 72 hours of birth. Second, treat for life. Dietary management must continue indefinitely, even in adults. Third, protect the fetus. Maternal phenylalanine must stay between 120 and 360 micromoles per liter before and during pregnancy. Fourth, test for tetrahydrobiopterin. The tetrahydrobiopterin loading test identifies cypropirin responders, so do not miss them. Fifth, monitor closely. Weekly phenylalanine checks during pregnancy, illness, and dietary lapses are essential. Sixth, team-based care. Dietitian, geneticist, and psychologist collaboration improves outcomes. Follow Pediatric Case Review for more case-based lectures and drop your questions in the comments. Thank you for joining this Pediatric Case Review lecture on phenylketonuria. I hope you found this case-based review informative and useful for your clinical practice. Please remember that these lectures are for educational purposes only and do not constitute medical advice. Always consult current guidelines and specialists for clinical decisions. If you have any questions, please comment below. Follow Pediatric Case Review for more evidence-based clinical lectures. See you in the next one.